So today we're looking at Skin Integrity and Wound Care, Chapter 33, and then Urine and Bowel, which is Chapters 38 and 39. When we look at the skin, we should know that it is the largest organ of the body, and it has multiple functions: protection, temperature regulation, psychosocial, sensation. It has vitamin D production, even immunologic functions, absorption, and then elimination. That's where we sweat. Table 33.1 on page 1152 has each of these functions and a description. So when we look at the epidermis, this is the top layer of the skin. You can see in this picture here, it does not have its own blood supply. It really depends on the lower layers, the dermis and the subcutaneous tissue, to provide it the blood, oxygen, and nutrition. When we look at the dermis, this houses all of our nerves, hair follicles, sweat glands, also blood vessels that help nourish the blood, the epidermis. And then finally, you have your subcutaneous level down here, and this stores fat for energy and protection of the body. Also houses blood vessels, lymph vessels, nerves. Next, we want to look at different factors that affect skin integrity. And also, when we go back and think of wounds, that's when you have any type of damage to the skin. So with age, those that have older adult or fixing to start older adult, you have talked about this in there. Thinning of the skin in aging individuals makes them much more susceptible to skin tears, lesions. If they're on anticoagulants, it will have hematomas under the skin. The skin also becomes drier and healing time can be prolonged. Also, the collagen fiber is lost, so elasticity is poor. So that also increases risk for skin tears, shearing, and breakdown. Lifestyle factors, different variables that we can think about would be occupation. This could be if you were out in the sun for a prolonged period, could increase your risk for cancer. Body piercings can also increase risk for infection. So, you want to assess that for redness, swelling. When we look at health status, illness, we really think about hydration and nutrition. Poor nutrition is really going to cause poor wound healing and overall poor skin in general. If you go back to health assessment and you think about hydration, when you check skin turgor, if there was tinting in place, that meant the patient could be dehydrated. So you can think about that. Also, reduced pain sensation in extremities. This can be with patients who are diabetic. They can have that diabetic neuropathy. If there's any type of circular insufficiency or nerve damage, so they cannot sense this injury or friction issues that they may have. When we look at diagnostic tests, a lot of tests for GI requires bowel preps. And then that also can irritate around the rectum and then cause breakdown. So you can think about those different things. Or if a patient has chronic diarrhea, that goes back to illness. So therapeutic measures, bed rest. If a patient's on bed rest, that does put them at high risk for skin breakdown. If they're on different types of medication, if they have an allergic reaction, they may develop a rash. Radiation therapy can destroy the skin and it causes like a burn. And then also different cancer cells can't differentiate between healthy or non-healthy cells. So it destroys them all. So now we're going to look at classification of wounds. You have intentional versus unintentional, open versus closed, and acute versus chronic. So intentional wounds, these are created for therapeutic purposes. Maybe it's a planned surgery, that could be an incision. Usually it's not a lot of uncontrolled bleeding. Edges are usually clean and concise. There's low risk for infection. Unintentional would be high risk for infection. This is usually from like a trauma or an accident. Wound edges are usually not clean and they're jagged. And usually with this, it takes the healing process and the repair process a lot longer. For instance, my son cut his foot on a bottle in a pool in the bottom of his foot. So it was an area that's hard to heal anyway. It was jagged and deep, and so it took a very long time to heal. So open versus closed wounds. Open, of course, skin is broken. The underlying tissue is visible. This can be a laceration, a puncture wound. Closed, the skin is not broken. This could be ecchymosis, which is bruising, or a stage 1 pressure injury. When we look at acute versus chronic, typically repair with acute goes through the normal process and heals much more quickly. With a chronic wound, the healing time is usually delayed. It can be months to even years. The skin, the wound is usually not approximated, which means it takes longer to heal. Usually when you're documenting if you have a wound and it's like a normal incision, you'll say the incision is well approximated, which means it's straight line, it's healing well. Usually with the chronic wounds, they have other issues that inhibit wound healing. This could be diabetes, either arterial or venous ulcers, or pressure injuries. So when we look at wounds, how would you classify these? So here, this is an open wound, of course, and this is also unintentional. Closed wound, intentional wound. This would be a chronic. This would be acute and unintentional. I don't even know. You probably couldn't even see which one I was pointing at. Okay, so the top left, this would be a open. The bruising, bottom left, would be a closed. The middle IB start would be intentional. The blister would be unintentional. This could be chronic on the bottom of the foot. Okay, when we look at types of wounds, and this should be table 33.3 on page 1155. So we have your basic incision, and this is through a sharp instrument. The incision is well approximated, it's aligned, and the edges are intentional. When you have a contusion, this is usually maybe from a blunt instrument, the skin is intact, and there's injury to the tissue. And this is a closed wound. When you have an abrasion, usually this is unintentional and it's open. This can be from friction, it can be from falling, it could be carpet burn. Those are some examples of abrasion. Laceration is open. This is tearing of the skin, and usually it's with an irregular instrument. It could be like if you opened up a can and cut yourself with a can, or if you were using a sharp knife and cut yourself with a knife. When you think about puncture and penetrating, these are usually open. And the difference is the puncture doesn't still have the object lodged in it. Penetrating still has the object lodged in it. With venous ulcers, this is usually from an underlying incompetent valve. And this occurs when there's poor venous return. The blood pools down in the feet and can't get back up. It doesn't have that blood flow. And usually see a lot of swelling in those lower extremities. So that's when we talk about bed baths, we always want to go from distal to proximal to promote that venous return. When we look at arterial ulcers, these are usually from underlying ischemic conditions. So think about atherosclerosis. Maybe the patient has a DVT or a clot that results in ischemia of the leg tissue itself. And then you can have diabetic ulcers. These are usually seen on the feet. And this is because of the underlying diabetic neuropathy. And so because the patient can't feel that they've been injured by an object, or maybe they stepped on a tack or a nail, or they just injured themselves, that's what happens. So here's a question for you. Which type of wound is caused by a blunt instrument that causes injury to underlying soft tissue with the overlaying skin remaining intact? What will you choose? So the answer is A. It's a contusion. Contusions are caused by blunt instruments. Abrasion is the rubbing or scraping of the epidermal layers of the skin. Laceration is the tearing of the skin and tissue. And avulsion is a tearing of the structure from a normal anatomic position. So when we talk about principles of wound healing, these are the major components that you have to think about. Hand hygiene is key. You always provide hand hygiene. Wash your hands to prevent infection. An open wound is the highest risk for infection. Adequate blood supply is essential. So areas with better blood supply tend to heal quicker. Usually these are those closer to the abdomen. Sometimes those without good circulation can have prolonged healing times. This is also why pressure ulcers take so long to heal, is because they are in that constant pressure and they have decreased blood flow. And that's why you constantly have to move them, and sometimes they don't even heal. Foreign material should be removed. So any foreign body should be removed from the wound. This is why in surgery, you always do like a sponge count, a instrument count to make sure there was nothing left, because that will set up for infection because it's a foreign thing and the body reacts. Also, any dead or damaged cells should be cleaned out in most cases of a wound. That's usually why if it's an unintentional wound, like a cut, it is flushed out, the debris is removed. For example, with my son, when he had his laceration on the bottom of his foot with the glass, they did x-ray it to make sure he didn't have any glass broken in there, because again, that is a foreign body and you don't want to keep it in there. Again, general health status plays a large part. So the elderly, older adult, and those with more comorbidities will have a harder time healing. Again, these are the constants with this: diabetes, arterial or venous disease, and then those with poor nutrition. So when we talk about nutrition, we have to think about vitamins, minerals, everything that's essential for wound healing. So if you have a poor nutrition, this will always affect the healing negatively. So we'll look at those prealbumin, albumin levels to see the patient's nutritional status. We'll also look at their weight and how much they're taking in at meals. So when we look at factors that affect wound healing, we have local factors, which is pressure. When you have pressure, like a bony prominence is pressuring and it's putting pressure on that part of the body, It interrupts the blood flow to the lower layers of the skin, and then because of that, it begins to get necrotic over time because of that lack of blood supply. So that's why it's very important that with patients who have decreased mobility and limited activity, that they are turned and off of those bony prominences or pressure points. The next one is desiccation. This is drying up of the surrounding cells in the wound. It delays healing, so wet wounds are usually better and heal quicker. Maceration. This is healthy skin is exposed to wetness for too long and it leads to skin breakdown. This can be from incontinence or if a patient has sweated in the bed a lot. You know, when you put your, if you have your hands in the water a long time, like pool, bathtub, they are like waterlogged. That's what that is. So because of that, the skin can break down easier. So that's why it's very important that we provide incontinent care. And if a patient has sweated a lot, we want to change their linens and get them dry linens. Of course, trauma is going to take longer to heal because they're unintentional, usually open wounds. When you have edema, this can affect the blood supply to the area, which can affect healing. It slows it down. Again, infection. That's why you want to prevent infection because that does affect healing. Excessive bleeding, because the area is not getting enough blood supply. And then necrosis this is when the area is dying. When we look at systemic factors, age, we have the aging adults tend to have more comorbidities along with changes in their skin texture. Circulation, decreased oxygenation and blood flow will delay wound healing. Again, diabetes, peripheral vascular disease, peripheral artery disease. Smoking is also a big factor in this, and obesity because of the decreased oxygenation and blood flow. Again, nutrition is a major thing because it can delay wound healing in general. Again, the patient's albumin level to know their nutritional status. When we think about medications, steroids can cause a delay in healing and increase the risk for infection. And then you also think about radiation and chemotherapy. Those can decrease the immune responses and also then increase risk for infection and delayed healing. Skin should be assessed in the acute care setting at least once a shift. And again, as patient changes, their status changes. When a patient is admitted into the hospital, their admission, you automatically do their admission history, but you should also do a full head to toe physical assessment, especially with pressure ulcers and our CMS guidelines. Because if a patient comes in with a pressure ulcer, the hospital is not penalized because they may have developed a health care acquired pressure ulcer. So that's why documentation is very important. So if they come in with any type of abrasions, lesions, pressure injuries, and you need to figure out what stage it is, any type of wound, it needs to be documented on admission. All right, I have another question. So which wound complication is caused by overhydration related to urinary and fecal incontinence? Necrosis, that would be dying tissue, edema, swelling, desiccation, drying out, maceration. Yes, because this is where the skin is very wet and it's easy to break down. So when we look at wound complications, there's dehiscence and evisceration. These are very, very serious postoperative issues that you see. Not commonly, but they do happen, and they're often seen in abdominal surgeries, and usually they're seen in larger patients. Dehiscence Again, it's greater risk if you are obese, smoke, or malnourished, or if you cough or nausea or have nausea or vomiting, because the wound just opens up. So that's why it's important, if the patient has had abdominal surgery and they have a major incision, that they splint themselves with like a pillow or something. When this happens, it feels like something's popped or kind of given away, and so that wound separates. So if this happens, you immediately cover it with sterile saline-soaked sterile towels. And then you call the provider immediately, and they will take them back to emergency surgery. So you can see the top one, that's where the wound has dehisced. The bottom one is evisceration, and this is separation or protrusion of the underlying organs. And it's where the viscera comes out. You can see the organs in that picture. Again, you cover it up with sterile saline soaked towel so it doesn't dry out. Place the patient in low Fowlers, and the surgeon will be called immediately. And do not leave the patient alone. So other wound complications, infection. This first picture, you can see the purulent drainage. This is usually happens more with the open, unapproximated wounds. You've got the purulent drainage. There's pain, swelling, erythema, fever, increased white blood cells. If the infection, like if it's a pressure injury and is directly over a bone, or it could be a wound, maybe a knee surgery, and is directly over the wound, the patient's high risk for osteomyelitis. And this is an infection of the bone, and it's very difficult to treat, and it has to be treated with IV antibiotics. I remember when I was in nursing school, I had a patient at the VA who had osteomyelitis of the knee, and it had a very, very malodorous smell. And my nursing instructor, we wore masks in there at the time, and then we had put alcohol on the mask, so I'm not even sure how I breathed when I was doing the dressing change, but we did it. The next one is hemorrhage, and this is bleeding from the wound. So that's why it's very, very important for you to assess your wounds and the dressings to make sure there's no bleeding. If this happens, extra pressure can be applied. Make sure that you always check under the patient too, because if the wound is draining underneath them, you may not see it. And so you always want to make sure that blood isn't pooling somewhere else. The next complication can be a fistula, and this is a tunneling or passageway, you can see in the picture, that shouldn't be there, and is created between a wound and an outside portion of the body, or between one structure and another. So these frequently happen in abdominal surgeries, forming a fistula either to the anus or vagina, and usually from a previous infection of that wound site, and then it formed an abscess. When we look at pressure injury development, pressure injuries used to be called pressure ulcers, bed sores, decubitus ulcers. These are the different terms they've been called over the years. So right now they're called pressure injuries. So you have your bony prominence, and you have the body weight going down, the blood vessels collapse, and because there's no blood flow, necrosis begins to happen, and then the wound develops. So you have these pressure areas from the body weight. Ultimately, it leads to ischemia or necrosis of the tissue. Again, these usually occur from these bony prominences, And they're like the back of the head, the ears, shoulders, shoulder blades, elbows, the gluteal muscles, the sacral areas, the coccyx areas, ankles, knees, heels. So anywhere that something may be pushed against for a period of time. There was a patient before where somewhere I worked, and they were placed on a bedpan for a very, 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 very long period of time, and no one took them off of it, and they developed a pressure ulcer the shape of a bedpan on their buttocks area. And that was terrible because that was uncalled for. Also, friction can cause pressure injury development. Again, this is those two surfaces rubbing together. Think about a patient falling down in the bed when you're transferring from one to another, and it's that friction. Also, you have to think about friction and the wrinkles in the sheets. That's why it's very important that we don't have any wrinkles in the sheets. Shearing is when the layers of the tissue slide against each other. This also happens in older adults because of their more sensitive, thin skin, so we have to be very careful with that. So when we look at risk for development of pressure injuries, the biggest cause of pressure injuries is immobility or activity limitations. So high-risk patients are those who are immobile, even though in wheelchairs, have pressure points. Those with poor nutrition, incontinence, altered sensory perception. Again, you need to know where the pressure points are. Poor nutrition, look at your albumin and pre-albumin levels. Albumin gives us more of a chronic or long-term nutritional status. Pre-albumin levels gives us acute, what's happening right now. Albumin 3.2 or below, or a pre-albumin below 15 is concerning for their risk for developing pressure injuries. Again, moisture, we talked about maceration earlier. We want to keep the patient dry, and this is both from incontinence and sweat. Also, unhealthy wounds need moisture to heal. You want to make sure the skin around it is dry. And then altered mental status, you want to make sure that a change in this makes the patient less aware of their surroundings, and so they might not perceive everything, so they may not think about turning in the bed like they should. And then again, age because of the skin. Here, these are the different types of pressure injuries, and these are stage 1, 2, 3, and 4. You need to know these. Again, common over bony prominences, anywhere that's touching something. This can be the heel, sacrum, back when lying in bed for prolonged periods of time. Again, the reason is because of the lack of blood flow. So if you look at stage 1, the skin is always intact. There's local redness. It's non-blanchable skin. So again, just redness that does not blanch. So you know when you like with your fingertip and you touch your skin, you can see it blanches white when you lift up. So the skin does not blanch. Stage 2, it's superficial, shallow through the epidermis. The wound bed is usually red or pink because there is partial thickness. That's the key word for stage 2 is partial thickness. It looks like a busted blister. You cannot see fat or muscle. Cannot. Stage 3 extends through the dermis. So the key word here is full thickness loss. It has to do with, it goes through the subcutaneous fat and granulated tissue is visible. It can kind of look like a crater. Usually the wound edges are rolled. And again, that is full thickness. Stage 4 extends through all layers of the skin, exposes muscle, tendon, and bone. There also may be tunneling. Again, this is where the wound has tunneled around. If you do have a wound like that, you will have to pack the tunneling. It makes it a lot more worse. It's wider, it can be deeper. You measure it with your Q-tip, the sterile Q-tip, and then you document like with the face of a clock. And then when a pressure ulcer is unstageable, which we'll talk about in a minute, usually that's because there's eschar in place or the yellow slothy tissue. So when we assess wounds, it's important, again, to use the clock face to highlight different areas. Like if there's undermining goes right along under the edges, and then tunneling, as it sounds, it tunnels. When there's an acronym, we can talk about it. It's TACO. It's the type, amount, color, and odor. And this has to do with the amount of drainage. What kind of drainage is it? How much? What color is it? And does it smell? And then you always want to measure like the width and depth of the wound. So like I just talked about, unstageable. You can see on the left on the heel, that's eschar. And because you can't see, so that is unstageable because you can't see the wound. It has to be removed in order to stage it. The slough is made of dead tissue. It can be yellow, green, brown, gray, stringy, and it can be attached to the side of the wound. Usually the provider will go in and debride this, and this can be either done at the bedside or in surgery. And the eschar, that's the dead necrotic tissue. It's usually hard and dry. And we should not remove that. So what stage do you think this pressure ulcer is? If you look closely, you can see bone. This is the sacral bone. So this would be a stage 4. So when you look at this one, and you will have to identify a type of pressure ulcer. So you can see here the skin is intact. If we tried to blanch, like this would be non-blanchable skin. So this would be stage 1. And going back on, I want you to refer to page 1162 in your book. These are common sites for development of pressure injuries. And it shows like if the patient was in the bed and then also the wheelchair. And then on page 1163, box 33.3, risk factors for pressure injury development. So here we are looking at what's what. Know your exu date. So the drainage. So when we look at serous drainage, it is clear and watery. It's mainly composed of blood and serous and fluid from serous membranes. It's just clear and watery. Serosanguinous is a mixture of serous serum and red blood cells. So because it has that red blood cells in it, tends to be like a pinkish color. And then you have sanguinous, which is mostly blood, a lot of red blood cells, so it's bloody. You can have again, back to the serosanguinous where it's mixed together. And then you have purulent drainage, and this is a lot of white blood cells that's liquefied. There's dead tissue, bacteria. It can be green, yellow. Just really depends on the type of bacteria. It can be really thick, and it's usually in some type of infection, and usually you'll get some type of specimen sample and to see what is growing. Again, you want to talk about it with the drainage. Taco. type, amount, color, and odor. So when we look at the RYB wound classification, this is just an easy way to look at your wounds and like the wound bed and say, okay, if it's red, we want to protect it. If it's yellow, we want to cleanse it. If it's black, we want to debride it. We really want to debride it, but someone else will. The red wound reflects good granulation tissue or a normal color that you would want to see in the healing process. A lot of times this will be gentle cleaning with saline. You usually keep them moist with saline dressings. You only change it when necessary or as ordered by the provider. When you have the yellow, usually the yellow from drainage is either that exudate or slough. Usually needs to be irrigated well to get rid of the dead bacteria before changing the dressing. So you might irrigate it, and then because you're always going to do the provider orders, or if there's a wound care nurse, then the nurse may write some orders out for wound care. So the black wound, those are the wounds that have the eschar and need debridement. And so once debrided, it's usually considered yellow, and then it will eventually move back to the red, which is healing, and we want to protect it. And that is on page 1171, box 33-5. So here, this is how the Braden Risk Assessment Scale, this is how we determine if our patient is at risk for developing a pressure injury. And usually this is standard in most hospitals. So it focuses on mental status, continence. Do they stay wet? We don't want them to have any maceration. Mobility, activity, and nutrition. So the higher the score, the less the risk. The lower the score is the most severe. So if it's lower than 12, it's very severe. And so we should be documenting this at least once a shift. So now, like, what nursing interventions, what are we going to do to prevent our patient from developing a pressure injury? So back to the nursing process, we are going to assess first. We're going to assess frequently, especially those bony prominences. We are going to cleanse the skin after urinary and bowel elimination. We're going to provide that incontinent care. We're going to use moistures as needed. We're going to protect the skin. If the patient is incontinent, there's different types of barrier creams that we can place on the patient to protect their skin. We are going to turn and reposition the patient every 2 hours. We can do this with pillows. We can do this with the heel protectors. We'll have a turn schedule, and usually that's on our whiteboard that we communicate with. We can use tissue load management surfaces, and these are the beds. I have a slide in a minute I can show you that the air pressure changes, and so it allows the pressure to be released and off of those bony prominences. Again, we're going to assess their dietary intake, make sure they have got enough protein. We're going to check their labs for their prealbumin levels. We're going to improve their mobility and activity, and then we're going to document everything. Remember what I said earlier, we have to document everything on admission so the hospital does not get penalized. And then you document every shift and as needed. Again, here's a picture of those pressure points. There's an example with the wheelchair and a patient laying supine and on their left side. Here are some different airflow mattresses that patients can have on their bed to help prevent pressure ulcers. Okay, now we're moving to different types of drains. A lot of time a patient may have a wound and they have different drains. So the first one, the Penrose drain, this is an open system. It's an open drain, and it allows drainage, and is usually used after surgeries. And usually there's you keep like a 4x4 or something up there so it doesn't leak out. But it's a soft, rubbery looking tube that's inserted inside the wound, and then it's left outside the wound to drain. Then you have a chest tube. This is a closed system, and the chest tube chamber has got to have a certain amount of water, and depending on if it's just suction or not suction. And the chest tube inserted into the pleural space, and it allows fluid to drain out. This can be done from cardiac surgeries. It can be done if a patient has a pneumothorax. The JP drain, or a Jackson Pratt drain, this is like similar to a bulb suction device, but it's often used in a lot of surgeries. And then usually it holds up to about 50 mils, and usually you keep it compressed. There's the hemovac drain. Usually these are used in a lot of orthopedic surgeries. There's negative pressure suction that's applied, and it drains blood and fluid, and it holds a lot more fluid, up to 500 mils. Again, with the JP and the hemovac drains, you have to remember when you empty them out, you have to measure how much drainage came out of the drain, and then you have to squeeze it back and apply that pressure after you empty it out. All right, here's a question for you. The nurse would recognize which of the devices as an open drainage system. So again, that would be the Penrose as an open. When we look at different types of dressings, you have your dry gauze, non-adherent gauze. Non-adherent gauze we've also called in the past like Telfa dressing. Special gauze, these can be like a if a patient has a peg tube in their abdomen, and it's got the little split on it so it can go around that device. And then you've got your opsites, or your transparent films, and these, that way you can still visualize like the IV site, because you should never put any type of covered dressing over an IV site, because you have to be able to assess it. Okay, now we're moving to chapter 38, urinary elimination. So one of the things that you need to know the difference between is urinary incontinence versus urinary retention. Urinary incontinence is an involuntary loss of urine. This could be stress incontinence. It could be just total urinary incontinence. Urinary retention is where more urine is produced, but it isn't being excreted. And this usually is seen with like certain medications, prostate issues, maybe a prolapse of the vaginal wall. Also, frequency of urination can change the risk for certain things. So less frequent urination will put you at high risk for urinary tract infections. The longer you hold your urine, the higher your risk for getting that UTI. So effects of aging on the urinary system, which we're going to go over this briefly because you cover this in older adult, or you will. There's the decreased ability to concentrate urine. So a lot of times patients may have nocturia. This is having to urinate at night. There's decreased bladder muscle tone. This increases their frequency. You have to go more often. And then there's a decreased bladder contractility. So it doesn't contract as much. So there may be more urinary retention. The longer you hold your urine increases the risk for UTIs. So when we look at nocturia and frequency, we don't want to completely discourage fluid intake before bed. We don't want to limit fluids, but we also don't want to have to drink like caffeine products right before we go to sleep, or alcohol, because they are diuretics and then they will keep you up. Ensure easy bathroom access, evaluate medication, use of night lights. You also have to think about medications too. For patients on a diuretic, you don't want to administer that medication at 9 p.m. So usually the latest time in the day a patient is given Lasix or furosemide would be 5 p.m. That way they aren't up all night having to use the restroom. Incontinence, discourage use of alcohol, caffeine, and artificial sweeteners. Again, these are diuretics. You do want to make sure that the patient does maintain a good fluid intake of 1,500 to 2,000 mils a day. And then to prevent UTIs, we want to encourage showers, frequent perineal care, void frequently and immediately following sexual intercourse, avoid vaginal sprays, deodorants, powders. We want to make sure that we do have adequate fluid intake. Sitting in the tub of water for a long time is also puts patients at risk for UTIs. And then again, voiding frequently. So nurses are known for holding their pee forever. So don't hold it. Go to the bathroom so you do not develop UTIs. So another thing for urinary incontinence, especially stress incontinence, is pelvic floor muscle training. And this can be where you contract the pelvic floor muscles like times 10 seconds. Another way that it's done is you can teach your patients to help control the stream of urine. So like if they're voiding, then they can stop the stream, hold it for 10 seconds, let it go. And this kind of helps with incontinence. Also encourage the patient to not use the muscles in the abdomen or the thighs. This needs to be performed multiple times a day. They also have physical therapy that does this now, and they also use these little weights. So that's something new too. So make sure you know this terminology. Box 38.1, page 1454. Anuria is less than 50 mils of urine after 24 hours. So this is a definite problem. Dysuria is painful urination. Frequency, of course, this is increased urination. Glycosuria, this is glucose in the urine. Years and years and years ago, how doctors used to know if a patient was diabetic or not is they would drink the urine, and if it was sweet, they know they had sugar because it had glucose in it. They would know that. So glad we don't do that anymore. Nocturia is nighttime urination. Oliguria, this is less than 400 mils in a 24-hour period. Polyuria, excessive output, diuresis. This is when the patient's constantly going. Proteinuria is when there's protein in the urine. Pyuria is pus in the urine. I can't talk now. And then urgency, this is, when you got to go. Strong sudden desire to void. And then incontinence is when the patient is unable to hold it and they have an incontinence episode. When we look at the characteristics of urine, this is on table 38.1. So normal urine should be pale yellow straw color. It may have a small ammonia smell. It may not. The turbidity, it should be clear. You can look at the lab values for the specific gravity. It can have urea, uric acid, creatinine. So if it was abnormal, the color could be darker. If it's more concentrated, if you haven't had many fluids, it could be a lot more concentrated. It could have an odor. If it's sweet, it could be some glucose in there. It could have a smell of infection. Also with odor, again, if it's very concentrated, it could have a very, very high ammonia smell. Also certain foods, and it depends on the person, they may smell different. Some people, urine smells funky after they eat asparagus. And then again, sometimes with UTIs, the urine can smell very, very rancid. With turbidity, abnormal would be cloudy. This is likely because of infection and red blood cells. Specific gravity, it'll be very concentrated unless diluted. And then abnormal could include blood, pus, albumin, glucose, ketones, bacteria. I had a patient one time and with a student, and we were putting in a catheter, and we were anatomically in the right place, but we kept waiting. And I'm like, well, we know we're in the right place. I'm not sure why there's no urine coming out. But slowly down the tube of urine, it was so thick from infection. It just kind of oozed down the tube. And so she definitely needed IV fluids for rehydration and antibiotics because it just kind of oozed down the tube. It was just white and thick. When we look at factors that affect aging, urinary elimination, aging is one of them again. We look at developmental infants. They have no voluntary control of micturition or voiding. Older adults may have increased urinary frequency, retention and stasis, or the inability to hold their urine because of the bladder and the hypertrophy of it. Food and fluid intake, again, caffeinated beverages, alcohol have that diuretic effect. Foods high in water increase urine production. Again, those high in sodium cause retention. You also have to think about psychological variables. For some people, voiding in a public place won't happen. Sometimes you have to say, okay, I'll just turn around. It's very personal and private to them, so you just have to give them that privacy, but also make sure they have their safety at the same time. Stress can cause people to void in smaller and more frequently. So because they're stressed, those perineal muscles and the external sphincter may not be relaxed, causing them to feel like they need to go, but not completely emptying out the bladder. Activity and muscle tone, again, immobility causes a decreased bladder and sphincter tone, so patients need to be up moving if possible. There's also other causes of decreased muscle tone. This is childbearing, damage to the muscles from trauma, muscle atrophy due to decreased estrogen levels in menopause. Also, then there's pathological conditions like renal or urological problems that can affect the quantity and quality of urine. Patients with congestive heart failure causes fluid retention and decreased urine output, so that's why they have to have the Lasix. Again, decreased physical activity can interfere with toileting. And then certain medications, we have to think about our nephrotoxic drugs. I'm sure you're learning about this in pharmacology. They can cause kidney damage. You have to think about aspirins, NSAIDs, some antibiotics. Again, diuretics can cause increase in production of urine. Some drugs can cause a change in the color of urine. Elavil, antidepressant, can turn urine a blue-green. Levodopa can cause a brown or black urine. So anticoagulants can cause a red color urine because of blood. Diuretics, because it is less concentrated, will be a pale yellow. Pyridium can cause the urine to be an orange to orangish red color. Again, Elavil, the green or blue, and Levodopa, black or brown. Okay, if you can see this is like the different colors of urine. You can take a look at that little image. All right, here's a question. So a male patient has outpatient surgery, is unable to void while lying supine. What can the nurse do to facilitate his voiding? So most male patients, stand up to void. So assisting him to the standing position can facilitate that. Okay, we went over this a little bit. Urinary tract infections, again, risk factors, sexually active females, postmenopausal females, females that use diaphragm contraceptives, diabetes, older adults, and again, we all know the catheter use, Foley catheter. That's why we try to prevent it and not use a Foley catheter. I will show in class about a PureWick, that's like an external urine collection system. Signs and symptoms of UTIs is dysuria, that painful, frequency, urgency, cloudy urine, and foul-smelling urine. So how to treat it? We want to increase fluids, observe urine frequently, make sure the perineal area is cleaned from the front to the back, void after intercourse, encourage showers, and cotton underwear. With the older adults, the first sign you usually see with the UTI is confusion. And usually this subsides once they have antibiotics. So when we look at the major types of urinary incontinence, there's 4 types: stress, urge, mix, and overflow. So stress incontinence, this is when there's an increase in abdominal pressure and poor tone. This is really common after childbirth or menopause in females. Even obesity can cause it. It usually doesn't happen when lying down, but happens when any type of stress, like coughing, laughing, sneezing, jumping. Urge incontinence usually doesn't happen when lying down, but will feel a sudden feeling of needing to avoid immediately and typically cannot hold it until the patient gets to the bathroom. Mixed is when you have the two together, stress and urge incontinence. And then overflow incontinence, usually the bladder becomes overdistended. Usually this happens if the signal to relieve oneself is absent and the bladder doesn't know it's full. So this dribbling can occur. This can be seen with certain medication, but mostly this just usually happens when there's some type of neurological disorder and the bladder just isn't functioning like it should. A lot of times we want to determine if a patient is retaining urine in the bladder, especially after they void. So this would be called a post-void residual. It's the amount of urine remaining in the bladder immediately after voiding. So a bladder scanner is used to detect this through ultrasound. So it's just a little cart you push in, and after the patient voids, you can scan it over the bladder area. Less than 50 mL is normal. Greater than 100 is abnormal. We used to do this with in and out catheterization as well, but again, because it is invasive and we do not want to cause a urinary tract infection, we usually use the bladder scanners now. So when we have a urinary diversion, this is typically created using a section of the bowel, and it's formed into an like a new exit for the urine. So the bladder is removed, and so you have to think about, where does the urine go? So it kind of goes out of this bowel piece through the stoma to the outside of the skin and into a collection bag. This is their new bladder. The stoma immediately post-op will be a dark pink to red color. Initially, it will be large, but should stabilize after the swelling goes down. It will still protrude from the stomach about an inch. Mild bleeding may occur initially, but should stop quickly. If not, the provider needs to be notified. If the stoma has a pale color, that means there's anemia. If it's a dark red or purple or blue color, it means the stoma itself is ischemic. So you want to make sure also too, and then notify the provider, that the area around the stoma stays clean and dry, because you do not want any breakdown. Intake and output should be monitored strictly, especially immediately following the surgery, to make sure that it is working properly. And also you have to think about coping issues as well, because this is something new that the patient has to deal with. How hard is it to hide under their clothes? They have to think about self-esteem. Also things about like sexual activity. They can be referred to social support groups with other people that have been in this situation before. Next, we're going to look at types of dialysis. You've got hemodialysis and peritoneal dialysis. Basically, because the kidneys aren't working right, we have to cleanse the system, basically. So here you have hemodialysis, and then you may have a AV graft versus an AV fistula. And for hemodialysis to have one or one of these others, a needle has to be provided to access those areas. The blood is cycled through the dialysis machine, which filters out everything the kidneys would normally filter out. But because the kidneys can't filter it out, it has to be done through hemodialysis or peritoneal dialysis. And AV means arteriovenous. And when a patient has an AV graft or an AV fistula, you should not do their blood pressure on that arm, because it can mess it up and have to go in and have a brand new one. Oh, there we go. So for hemodialysis, you want to inspect the site frequently. You should be able to feel a thrill, so palpate for a thrill. You should be able to hear a bruit, and so it has that whoosh, whoosh, whoosh sound. This means the access site is good to go. You should always check for circulation before, but especially during hemodialysis. You will not be doing this, but you may observe it with a patient. They may come up to the unit and do it, or the patient may go down to a dialysis unit and have it. Hemodialysis is done every 3 to 4 days. If the patient's in renal failure, it can last up to 4 hours or more. Typically, it's almost half a day for the patients. It cannot be done at home. Usually, the patient must be going into a dialysis clinic, or if they're in the hospital, they'll have it done there. Peritoneal dialysis. There's the peritoneum, the lining of the abdomen, and it has a fluid called diacylate that is infused into the compartment. It's a sterile procedure because there's a huge, huge risk for infection. If you remember me talking about the patient that I had that he was on peritoneal dialysis. The peritoneum became infected. He had peritonitis because of this. It has to be done sterilely. Once it's infused by the process of osmosis and diffusion, all of the waste that was normally would be excreted by the kidneys is pulled out into the diacylate from the blood vessels, and the fluid is drained back out into these closed system bags. And so with this type of dialysis, the patient can do it at home, and they can do it 1 to 2 times a day. Again, they're at high risk for peritonitis. You monitor the white blood cell count and any guarding pain or bloating. Okay, now we're moving to chapter 39, bowel elimination. So, a review of the GI elimination. You got your stomach, small intestine, large intestines. Feces moves by peristalsis within the intestines every few minutes, but mass peristalsis occurs when you've finished a large meal and needs to push it through. When bearing down, the pressure inside the abdominal cavity increases, and this leads to lower cardiac output temporarily. And so during this process of defecation or bowel elimination, if a patient bears down excessively, they can actually decrease their cardiac output so much that they can have a syncopal episode, which is related to lowering of their heart rate. And this is called the Valsalva maneuver. A lot of times if a patient is in SVT, they will have them do this to bring their heart rate down. Just a little FYI. So again, just a review, here's the process of peristalsis. So when we look at age-related changes with the bowel, usually there's decreased gastric motility. So with patients, you want to encourage small, frequent meals, high in fiber, low fat, adequate hydration. You want to discourage the use of laxatives. With the older adults, the receptors in the rectum are not as responsive when stool fills up, so constipation is a very big problem in the older adult population because of the less gastric motility in general related to their peristalsis. Even though the GI motility is decreased, the stomach emptying time is a lot quicker, so they should have smaller meals more frequently. Again, high in fiber. Again, lots of fluids. Muscle tone is decreased, so ensure safety for ambulating, easy access to the bathroom, because they will have that feeling of urgency. There's also a weakened intestinal wall, so again, encourage high fiber diet, adequate hydration, and exercise. When we look at characteristics of the stool, so these are the questions, all the subjective data that you ask your patients. What color is it? The volume, odor, is it soft or formed, tubular shaped? Is there any waste residues of the digestion, like corn? Abnormal black stools, melena, could mean there's a upper GI bleed. If it's a bright red blood, it was lower. Do you know why it's an upper GI bleed if it's black? If it's a white clay colored, it could be because of an absence of bile. If it smells really pungency, there could be blood in the stool. I had a patient before that had very, very, very bad GI bleed, and it was diarrhea, so much blood coming out, and so the patient had a rectal bag, and every now and then, because there's so much gas that come out with it, the bag would have to be burped. And so I went in there to do that, but the smell was so pungent that when I came back out of the room, back to the nurse's station, I still smelled of old, bloody stool. And so I had to go outside and just air myself out, which was bad, but it just smelled that bad. Also, you want to look at consistency, whether it's liquid, hard round consistency equals increases time. So you want to look at also if there's any blood, mucus, or parasites. If there's liquid in there, that means the stool has spent less time in the digestive tract. So it hasn't had enough time to absorb and it hasn't been time to form. If it's been in there too long, you'll see more formed, even really hard. Constipation can be very hard, round, marble-like. If a patient is impacted, which we'll talk about this when we get to constipation, but if the patient's impacted, they'll have that large, hard stool that's impacted in them. So sometimes diarrhea will go around it. So the patient thinks that they're okay, but really just that liquid's going around it because it can't pass that large impaction. Also, again, with Clostridium difficile, C. diff, you will, once you smell it, you will know it. It's very liquidy. It's really hard to describe, but once you smell it, you know it. When we look at diagnostic studies for the bowel, cultures can be taken to identify bacteria. Occult blood means there's hidden blood somewhere. It can't just be seen by the human eye. It has to be looked through a microscope, and that is called a stool guaic. It's Guaiac. That's how you spell it. Pinworm specimens. This can be like a little cellophane tape. Usually the eggs are deposited at night. And if you use a flashlight, they'll like go back in real quick because I don't like the light. Endoscopy, there's an EGD, which is the endogastroduodenoscopy. And that's where they go down the throat, through the esophagus, the stomach, and the duodenum. Colonoscopy is the full large intestines, and then the sigmoidoscopy, that's just examining the sigmoid colon, the end part of the descending colon. Usually after those, the patient's very gassy. They'll have lots of gas because they have air in there. With the EGD, you want to make sure the patient can swallow well afterwards. And then with the colonoscopy and the sigmoidoscopy, you want to make sure that they are passing gas. With the EGD and the colonoscopy, conscious sedation is used. So the patient's out. They don't remember what happened. So preventing constipation. Nutrition is a big thing. The patient needs to have a high fiber diet, 20 to 35 grams. This is bran, whole grains, fruit, veggies. It's very important if a patient is on a high fiber diet, they also have adequate fluid intake with it. Because if you put all that fiber in there and you do not put the fluids in there, it's going to turn into a brick. I had a student ask me before in class, is this why they say you should a brick? And I was like, yes, that is why. Because if you have all that fiber going in and you don't have enough fluid, it is going to turn into a brick. So good fiber intake and fluid intake combined, and with exercise. My favorite saying is increased mobility increases motility. So if you're exercising well and high fiber, high fluid, you are going to decrease the risk for constipation greatly. So increased mobility increases motility. So laxative use. You want to educate your patients to limit the use of laxatives and only use when they need them. Because they become so reliant on them, then they aren't able to have a bowel movement without them. Stool softeners can be used for older adults. This just softens the stool. Also had a patient before that came in with a GI bleed, a rectal bleeding, and we were trying to figure out what the cause was. And then we figured out the patient was constipated, impacted, and the reason why he was having rectal bleeding is because he was trying to use a spoon to remove his impaction. So next, preventing and treating diarrhea. We want to encourage low fiber diet, just the opposite. Discourage spicy foods and dairy. Diarrhea would be more than 3 loose stools in a day, loose and watery. You want to make sure that with diarrhea that fluids are maintained, because the fluids are lost very quickly, so rehydration is a key element when treating diarrhea. Also, you may think about electrolyte replacement like Gatorade, Powerade. They have the liquid IV now. If it's bad enough, then the patient may need IV therapy, like an IV bolus of normal saline. Or we'll talk about that later with fluid and electrolytes. You want to avoid high sugar and rich foods. So like the bland diet or the brat diet, which is bananas, rice, applesauce, and toast. And then food safety to prevent diarrhea. This would be like separate cutting boards for meats and veggies, washing things thoroughly, not eating raw eggs or seafood, and refrigerating your leftovers quickly. So interventions for altered bowel function, there's medications that can be given for constipation. Also enemas, which you have learned about in lab. There's the soap suds, the fleets. We can also give like a little cocktail of prune juice. Fecal impaction removal. Sometimes this is a provider order to digitally remove a fecal impaction. Make sure you double glove for this. So you basically use your fingers to remove the impaction. And this, not my favorite thing to do or watch. You want to watch for a sudden decrease in heart rate and blood pressure because of that, initiating that vagal response. And is not comfortable for the patients either. Rectal tubes, like I talked about earlier, fecal management system. This is that uncontrollable frequent diarrhea or a GI bleed. And the main thing with the rectal tube is to prevent that irritation and breakdown around the perianal skin. We can also have bowel training. It involves teaching the patients about controlling what they can related to incontinence, whether it's food, fluid, timing, exercise. It's really trying to establish a pattern. And then we look at bowel diversions. We have our ileostomies and colostomies. Which one the patient gets depending on the reason why they're having it. Wherever the part of colon is diseased and which part is being removed will tell you where it will have to be. The ileostomy will be more liquid stool because it hasn't passed through the large intestines, whose primary job is absorption of the fluids. The colonostomy is in the large intestines, and the quality of the stool will depend on where along the track of the colon the stoma is created. And so the care will be the same way that we cared for the urinary stomas. So the appliances have to be changed every 3 to 7 days or when the seal breaks. Drain the bag before it gets completely full. You want to make sure that the clamp is on there tightly so it doesn't leak out. Avoid foods that cause gas or blockage. Also encourage adequate fluid intake. Avoid foods like beans, lentils, cabbage, eggs. Okay, a question? So a client tells the nurse that he takes laxatives every day but is still constipated. The nurse response is based on which reasoning? A, chronic constipation is nothing to be concerned about. B, a laxative that works by a different method should be used. If laxatives are not effective, the client should begin to use enemas. Habitual laxative use is the most common cause of chronic constipation. The answer is D. And that is the end. If you have questions, please post them on the Blackboard. We'll put a discussion post up for this lecture.